Hello and welcome to this discussion on BQ Prime. I am Vivian Fernandes. The topic is whether Rajasthan's Right to Health Act, legislated in March, is a model for other states to follow. The Act mandates free and equal access to health care to be provided to all residents of the state. The law ran into protests from private medical institutions and practitioners who are required to provide emergency medical care without insisting on being paid first. It has been clarified that if such patients can't bear the cost, the state will reimburse as per a schedule of charges. Our guest is Dr. Srinath Reddy, well known cardiologist and public health evangelist, if I may call him that. Dr. Reddy is founder of Public Health Foundation of India. He was its president and is currently its distinguished professor. Dr. Reddy, welcome to this program and thanks for setting aside time from your busy schedule.
A pleasure to have a conversation with you.
Dr. Reddy, we have had the right to education, the right to information, the right to demand employment under NREGA and the Forest Rights Act. So is the right to health an idea whose time has come?
Indeed, the right to health has been discussed and debated and demanded for a number of years. Unfortunately, the rights framework, which extended to other vital areas of human development, was not extended to health. And I believe there's been considerable debate that's been going on for some years, which after COVID, I think has reached a level of public recognition and demand that the governments are now responding to.
Sir, but does creating a right necessarily mean that we'll be able to access it or exercise it rather? Because we depend a lot on the private sector in our country and out-of-pocket expenses are very high precisely because the state has not been able to provide timely, free and equal access to all people.
Well, in order to assure health to people in any society, we need three elements. One is universal health coverage, which means a wide range of services from health promotion and disease prevention to timely detection, care, and as necessary, rehabilitation and palliative services as well. The whole continuum of care from prevention to palliation. The second element that's required is multi-sectoral action on many of the social, economic, environmental, and commercial determinants of health, right from water, sanitation, and hygiene, which we readily recognize, to food systems and nutrition, to environment, from air pollution to climate change, to gender, to education, income security. All of those are absolutely important. Now, the third element, of course, is the engagement of a fully enabled community in an active manner, which is not only capable of demanding services and asserting rights, but also contributing to setting the agenda for action and also monitoring the way in which the services are being delivered with efficiency and equity. Now, the right to health will actually encompass all of them, though some of the bills that have been brought forth, like, for example, the Rajasthan bill, is mainly focused on health care and service delivery related to that. It does talk a little bit about water and sanitation and to some extent about nutrition security, but it does not really extend to all the social determinants of health. There is also some reference to community engagement, but the platforms have not been clearly constructed. Having said that, even in terms of delivery of health services, we are currently living in a mixed health system that is evolved by default and not by design. We cannot wish away the private sector. I mean, if we had focused on strengthening and developing our public sector right from day one and continued to commit resources to that end, we would not have been in this situation. However, with a relatively enfeebled public sector and a proliferated private sector which is still growing, you have to bring all society's resources into play for delivering health services to everybody as I said, with efficiency and equity.
Mhm.
Now, for that, you need to have universal health coverage where the public sector sets the agenda, frames the design, brings in the private sector as per need and availability, but sets the terms very clearly as to what the deliverables are and what the accountability mechanisms are, and ensures that in the process, the private sector plays a constructive role rather than looking for merely profit maximization.
Mhm.
So we need to design that kind of a structure. The Rajasthan bill is a move in that direction. It doesn't really prepare the full framework, but I believe we should not throw up our hands and say nothing can be done. It is time for us to build that kind of a structure.
Yeah. Sir, healthcare is an area where there is clear market failure. Market failure is pervasive. And what we have is an exploitative private sector. Now, we can follow the UK model, the National Health Service, which is celebrating its 75th anniversary this year. But even there's a lot of lamentation about how broken it is. And I think there is, according to a New York Times article, there is a waiting period of 7 million people are waiting for medical procedures compared to 4 million before the pandemic in 2020. Now, if a developed country like the UK cannot assure quality medical care in a timely manner to its residents, can India at our level of development do it? Or do you think that you mentioned about our big private sector? How do we go up the private sector along with the public sector to ensure that there's universal quality healthcare access?
Well, as far as the first part of your question is concerned, I don't think we can actually get very defeatist or nihilistic and say nothing can be done. Well, the NHS is having problems in the UK, long waiting list, but partly because they also started disinvesting in the full primary healthcare infrastructure. So they focused a little more on hospitals, and that was where the problem came up. If you look at some of the examples in the West, the Scandinavian countries have delivered very well. You've seen France delivering very well. You've seen Germany delivering very well, universal health coverage. And why go that far? In our own neighborhood, Thailand is delivering universal health coverage very well. Vietnam is delivering universal health coverage quite well. And so is South Korea, though it is in the higher income bracket. So we do have examples. So I think we ought to really build upon our own understanding of the situation here, but use suitable global lessons in order to construct a health system that can deliver universal health coverage. Mm-hmm. Now, you referred to the private sector as having unbridled profit motive. Now, true, they're seeking profit maximization. But we are also seeing that they are seeking, demanding, and utilizing public funds through the various health insurance schemes that the central government and the state government runs. And they're also seeking a variety of concessions for their own growth. So when you bring them into the frame of universal health coverage, you ought to use your powers, both regulatory and financing, in order to set the standards for their performance. Mm-hmm. In terms of what are the cost controls, what are the quality measures, and all of these, and clearly make accountability a part of it. And if you can actually bring them into that frame, using the authority that you have as a government, then you will be able to bring the private sector also into a constructive role.
Sir, I was talking to the economist and social activist John Reyes, and he was saying that we can have a hybrid model where the public health infrastructure is a fallback option, and those who can afford it can have what is known as healthcare as an option on public services, HOPS. You know, those who can't afford it can, or those who want to, can of course access the public hospitals, but those who have the means can go to the private sector. Is that the hybrid model you have in mind?
I mean, people who want to go to the private sector are doing it anyway. Those who can afford it do it as a matter of preference. Those who can't afford it are doing it as a matter of compulsion because public services are weak or not available. So the answer is to strengthen public services, finance them well, make sure that you have adequate health workforce, good regulatory systems, and that you are actually ensuring that your supply chains are functioning very well. So all of those elements of strengthening the public sector health services are going to be critical. I mean, right from the health and wellness centers or the primary healthcare centers and the community health centers to the district hospitals, we need to strengthen the entire chain of services, not just build a few all India institutes of medical sciences with big buildings, but hardly any faculty to service. So we ought to really build our health system bottom upwards. And the private sector is actually stronger in the tertiary care element anyway. So I believe it's important that the public sector plays that role. Now, even as far as the tertiary care is concerned, we must strengthen our medical college hospitals and even bring in some of the tertiary care elements into the district hospitals. So the public cannot abdicate any space, but it can bring in the private sector as needed and ensure that the services are utilized not just by the rich, but also by the poor as needed.
Currently, various states, I think almost all the states, they provide subsidized medical health insurance. Like even in Rajasthan, we have the Chiranjeevi medical insurance scheme, which is free for the poor and for certain sections. But even the non-poor can access it by paying 850 rupees as premium per year, which is 50% of the cost to the government. What do you think of this subsidized medical insurance schemes?
I've been saying this for a while, saying that, yes, we cannot do everything overnight. So make sure that the state-funded health insurance schemes are available to the vulnerable sections, both financially and economically and socially vulnerable sections. But as far as the so-called missing middle is concerned, who are very vulnerable above the poverty line, but nevertheless very vulnerable to healthcare expenditure, try and bring them into the overall scheme through income graded premiums. There also you ought to have some sort of a standard. I mean, even the missing middle has many layers. So bring in income graded premiums. And as resources for public financing increase, try and bring all of them into the bracket of fully state funded. Anyway, primary care has to be available to everybody. Most of secondary care services have to be available to everybody. Some elements of secondary care and some elements of tertiary care would have to be possibly priced for people who are above the poverty line. But even there, life-saving tertiary care has to be available to everybody. You can't deny life-saving care. So you ought to be able to grade it. We recognize that our movement towards universal health coverage is going to be progressive in stages. But even there, we ought to build in safeguards, as many as possible, so that we are protecting people, even who are vulnerable in the mid-zone, the so-called missing middle. Therefore, I think the element that has been brought in by Rajasthan is a sensible one. But we ought to make sure that it's available to all people who seek to enter the scheme. There's one more advantage of this. The larger the risk pool, the lower, the better the coverage of services as well. For two reasons. One is it reduces the cost of care because there is risk sharing because of the risk pooling. The healthy subsidize the sick, and the healthy at any given point in time outnumber the sick. So you actually reduce the cost of care. Therefore, you can expand your benefit package as well. The other thing is, by bringing in more people into the scheme, you are also getting a buy-in from many sections of society in ensuring that the scheme is properly operated. Otherwise, if you have only schemes meant for the poor, they'll be poorly designed and poorly delivered, with the rest of the stakeholders in society not really being interested in its success. So I think the Rajasthan model is the way to go, and faster the better.
So the Rajasthan model is, of course, quite ambitious, but when I see the outlay in the budget, I find that they have only increased it by 10%. Now, is that enough? Should they not spend more on healthcare?
Well, Rajasthan, as it is spending more than many other states. Their health budget is about 7.4% of the entire state budget. So I don't think we can completely fault them for it, but we must try and ensure that they continue to increase the allocations commensurate with their ambitions and aspirations.
Mhm.
But having said that, having price regulation, having other methods of financial prudence by getting, for example, public procurement of medicines, equipment for not only the public hospitals, but also the private hospitals should be brought into that process so that you can actually reduce the prices through negotiated public procurement.
Mhm.
So
And I think
those are the
Tamil Nadu has a very good public procurement system.
Pardon?
I think Tamil Nadu has a very good public
Yes, Tamil
procurement.
Nadu has the best public procurement system. Rajasthan tried to implement it in a few districts. The Tamil Nadu model is something that we should adopt. And in fact, there is no reason why you cannot also mandate it for the private hospitals who are getting public subsidies through the insurance programs or otherwise. Say, okay, we will establish a full public procurement system, not only for the government healthcare facilities, but you also buy from there. We'll ensure quality, but you pass on the benefit to your patients by reducing the costs of care.
So since we are running out of time, what is the last comment? Now that Rajasthan has enacted this Right to Health Act, what should be the next step? Should it now set up what you call strengthen its public health department so that we start with prevention and not just begin at the curative level?
I believe that both rural and urban primary care are the fundamental foundation for a good health system, particularly for delivering universal health coverage. It covers the maximum number of people, provides the maximum range of services, and also is the most resource optimizing way of providing services. At the same time, the primary healthcare service, apart from being comprehensive and continuous, should also be connected adequately to district and medical college hospitals where needed in a bidirectional manner. So focus on primary healthcare, but make sure that the connectivity exists as needed.
Dr. Reddy, for those insights and for that blueprint of universal health access, thank you very much.
Most welcome.